At this point, it kind of already seems obvious, but just for the audience perspective, I'm curious on your standpoint and your position in this. When you're working with providers, I'm just curious, what are those deliverables that you talk about or pitch to them, and what really resonates with providers when they're working with medically home?
You mean before they decide to or after they decide to?
Either way, both.
So I have on an average day now 7 inbound calls from providers. In the entire 11 years that preceded this time, there weren't 7 calls. There weren't 3 inbound calls. There were 5 outbound calls. So 7 a day. And it's hilarious because I'm like that high school kid that could never get a date and gave up on asking women to go out. And now I'm sitting and the phone's ringing off the hook and I don't know what happened. It's not plastic surgery, that's for sure. So I would say that they have a point of view that they've evolved on their own independent of us. And I'll give you the feedback I've gotten, which is reliable in terms of if your audience is investing in healthcare. This is a reliable, probably statistically significant piece of data because I think I've talked to 130 systems now in the last couple of months. Even though there's 5,700 hospitals, the ones I've talked to represent probably the most significant portion of the academic medical centers, the specialty centers like oncology centers like MD Anderson, et cetera. And then it also represents the small community hospitals. So it's a good cross-section of the country. So they're calling for 4 reasons. One is Mayo announced that they're doing this with us. That's the first reason. Why does Mayo Clinic need medically home? And we have other partners, which I'm not going to mention, but they're all announcing. So, like, what do these guys got that these guys couldn't do on their own? So that's the first reason they're calling, because there is a mentality in healthcare that if the leaders are doing something and we're not, what did we miss? So that's the first reason. And they always ask me, like, why did they decide to do that? Why didn't they do it on their own? That's the first question they ask, Kyle. Second, our hospital is full. That was a call I had this morning. Our hospital is full. We have 3 hospitals. They're all full. We've got a budget to build a new tower for 40 beds at $2 million a bed. That's $80 million. That's the tip of the iceberg. The iceberg is what it's going to cost to maintain those beds. We've been reading about overhead. It's like, why are we building a hospital? Why don't we build virtual beds? That's the second reason they call. They're full. The third reason they call, they have risk contracts. They have an ACO. It's small. It's emerging. They're dabbling. They have 20,000 lives, 30,000 lives. But they know this is what's coming. They know CMS doesn't have enough money. Back to the fixed cost problem, borrowing money from China. There isn't enough financial capacity in the system to keep paying for hospitals. And they know that because they run the hospital. And their CFOs know that because that's why the CFOs are looking for new jobs. They know that the financial sustainability of hospitals is very, very shaky. So they want to get into a model that is patient branded with their hospital system, yet less costly. So instead of saying, I'm putting you somewhere else, I'm putting you at home. I'm going to set up a hospital in your home. The system. So do I make as much money as I make putting you in the hospital? I actually make more in a home hospital model. However, I have to backfill, meaning I just lost the patient to contribute to overhead in the hospital. My overhead is $7,000 in 4 days. That patient didn't get admitted. I don't have another patient. I'm still spending that $7,000. I need another patient. I need to backfill. So if I have a risk contract and I'm serious, that's another motivation of why they're calling. The fourth reason they're calling is the most interesting. All of a sudden, patients said, it's really dangerous to go to the hospital. I could die there. And my family's not allowed to visit me, and I could die there and not see them before I go. I don't go to the hospital. I'll stay home. And the number of people that are getting more and more ill at home because they're afraid to go to the hospital is growing. Rates in most, I shouldn't say most, in significant medical centers, the rates of ED activity has gone down significantly, and so has elective surgery because of fear of hospitals. So the fourth reason they're calling is, we've just assumed for 150 years that you're coming to us. You're not like not coming to us. We just assumed you're coming to us. And now all of a sudden you're not coming to us. You have insurance and you're not coming to us. What are you doing? I don't want to die. I don't want to come to you. That's the fourth reason they're coming. Now, the fifth reason they're coming is they got a combination of those things, and they're calling fast. They got people are not coming. They're building a tower. They're full, and they have a risk contract. I have a screen, like a grid that I keep of like why they called. But if you take the change in orientation around COVID sensitivity to hospitals, combine it with Mayo's decision to partner with us, everything else in the middle kind of goes along for a ride, and that's why they call. And the calls, I no longer have to convince them of anything. I don't try. I just sit back and do what I'm doing now, just listening and answering questions. There's no more of that anymore. I'm not leaning forward anymore, which is great. At 68 years old, it's wonderful to lean back.